Great. Welcome back, everyone, to the afternoon session of the House Healthcare Committee. It's still Wednesday, April 5th, and we're staying with S37 this afternoon, and we're hearing from Vermont Family Alliance. Renee McGinnis is with us first, and then Carol Kaufman will be joining us. There are documents on the committee page. So Renee, I'm going to turn it over to you to introduce yourself and then go with your testimony.
Okay, thank you. Thank you for allowing me to testify today before your committee. My name is Renee McGinnis. I am a member of Vermont Family Alliance, and Vermont Family Alliance is a parental rights and minor protections advocacy group. I'm going to go through this as quickly as I can to allow plenty of time for other people. So I would ask that you hold your questions to the end if anyone has any. And I did listen yesterday to the committee meeting, and so I just want to acknowledge, I want to preface my testimony with an acknowledgement that Representative Sinha is a gender affirming care practitioner, and that I can definitely tell that it is in his heart, the care and the welfare of these kids that are dealing with gender incongruence and dysphoria. I can definitely, it showed right through the Zoom meeting that he has a heart for these kids. So I just want to acknowledge that, and any comments that, any of my testimony, it's not an attack on any individual. And I hope that all of you keep in mind as well that although Vermont Family Alliance may have opposing views, we all have common ground in that we care deeply for the health and well-being of our youth and our children. So with that, I'll start with my document, if I may share.
Sure, I think so. Are you? I think Claire is giving you or has given you screen share capability.
Yeah, so I just want to start with the issue on suicidality, because that seems to be the driving force behind gender affirming care, the concern about the mental health and well-being of our youth. So there is a 2011 study out of Sweden that concluded that persons having received a sex reassignment have considerably higher risks of psychiatric morbidity, suicidality, and mortality than the general population. So there's a link to that. That's from the National Institutes of Health government website. So I know proponents think that they are reducing suicidality and improving mental health based upon the Trevor Project, which is a survey, it's not a study. I dug into it. I did not find any evidence-based studies on the Trevor Project website that conclude that gender affirming care saves lives and improves mental health. So I included the Trevor Project website as well for people to check out if they want to. When questioned by House Judiciary Committee members on comparative data on suicidality in states that affirm versus states that ban or limit gender affirming care, both Dr. Gibson and Polly Kozier provided anecdotal evidence and speculation on future data, and neither of them followed up with evidence-based data on suicidality. I couldn't find, under their witness names, I couldn't find any data for studies that were uploaded to the documents. Let's see, under any committee. They provided anecdotal evidence and speculation on future data, neither followed up with evidence-based data on suicidality, either independent of states or based upon comparisons of states' stances, and anecdotal statements about parents' fears for their children's emotional well-being were accepted as legitimate evidence. One of the studies from the Journal of Adolescent Health that was referenced on the Trevor Project website stated that there are no large-scale studies examining mental health among transgender and non-binary youth who receive gender-affirming hormone therapy. Secondly, Vermont prohibited female genital mutilation in 2020, yet vaginoplasty, orchiectomy, and phalloplasty are not considered mutilation. So I see a contradiction there. 3, childhood trauma is the underlying cause of poor mental health. This is an American Academy of Pediatrics study that indicates that childhood trauma is the underlying cause of anxiety and depression, which needs to be addressed with restorative psychiatric therapy, not directly going to gender affirming care. So yes, people who have youth and minors who suffer with dysphoria and incongruence can have anxiety, depression. Those can be symptoms of, but the gender dysphoria or incongruence itself might not be the root cause of their anxiety, depression. I think that is something that needs to be looked into more thoroughly. International standards of care. This first link is a link to a quick facts book. It's a short 8-page booklet on the side effects and complications from hormones and surgeries and the international status of gender affirming care. This booklet is from the website sexchangeregret.org, which was founded by a Walt Heyer, and he is a man who suffered childhood trauma, transitioned to a woman and back again. He's an author. He's written his story. He has received 2 million visitors to his website and over 10,000 emails from people who regret their transition. Pages 2 and 3 of the booklet, they provide the status on international standards of care. UK, Sweden, Norway, Finland, and France have all taken steps to protect children from hormones and surgery. I would, if you like, check out the research and the voices, especially the research and voices options under the posts tab of Walter's website there. And Jessa Barnard, she stated February 7th before the House Committee on Judiciary that there are national and international standards of gender affirming care. The World Professional Association of Transgender Health, which is an independent, unelected, non-governmental organization. Their standards are not necessarily being followed in Europe. So clearly, we all know there's a conflict nationally, whether national standards of care are ethical. There's disagreement between states, and we believe that Vermont is taking a position that's at odds with recent studies and may very well find themselves on the wrong side of history regarding gender affirming care. If you shield it with S37. The CAS review interim report on the Tavistock Gender Clinic in the UK, Vermont Family Alliance. I provided testimony for about 30 minutes on the summary portion of this 100-page report. The House Committee kind of just disregarded it. The study found that practitioners felt pressured to comply with gender affirming practices that go against clinical assessment and diagnosis practices. Control measures were lacking, and the study concluded that there's no conclusive evidence on the use of puberty blockers and cross-sex hormones. I believe that study is uploaded in the witness documents as well under my name. 6 puberty blockers, cross-sex hormones, gender assignment surgery. So very common are urological complications from bottom surgeries on both birth-registered males and birth-registered females. Some studies indicate 25 to 40% urological complications. Studies that I looked at are all over the map. I did not share any links because some of the photographs are pretty graphic, and I just, once seen it, you can't not see them. They're sad and disturbing. So I did not share those links, but I can, if someone wants to reach out to me, I will send them links to some of those studies. Urine leakage out of unwanted openings and urine blockage are common, possibly leading to kidney inflammation if left untreated. Puberty blockers, some of the effects are failure to grow, liver damage, mental health problems, skeletal damage, and bone thinning, infertility, osteoporosis, cardiovascular disease, brain swelling, loss of vision. And puberty is a process that helps our bodies develop healthy brains and bodies. The effects of disrupting puberty are not known. Cross-sex hormones for females taking testosterone, heart attacks, strokes, liver dysfunction, type 2 diabetes. For males taking estrogen, blood clots, heart attacks and strokes, breast cancer, weight gain, insulin resistance. Gender assignment surgery, 50% of birth registered males experience complications, pain, surgical site bleeding, urinary dysfunction, sexual dysfunction. And for birth registered females, hysterectomy causes permanent sterility. And the studies conclude that suicide rate is 19 times higher 10 years after surgery. A lot of this information came from Walt Heyer's website. Again, I refer you to the research on his website, or I can send you some studies as well. So the question is this the standard of care that will be shielded under S37 and H89? Consequences of S37 and H89, they both serve to shield practitioners who are mentally and physically harming minors and youth, or could be severely harming minors and youth. I'm not saying all of them are. Both bills target youth and minors. Statements in committees on the Senate floor and the joint resolution last year approved this in the language. Statements by Senator Lyons and Jessup Barnard have made it clear that all mental and medical health practitioners licensed in Vermont will be held to the standards of care determined by medical boards without conscience protections. The House dismissed Donahue's conscience protection amendment for H89 is not germane. So this one coming up here, after listening to yesterday's testimony, I would probably, if I could go back, probably change that. So it's confusing to me whether or not S37 and H89, if a healthcare practitioner, according to their conscience, did not want to treat a patient, would they be required to refer that patient to a gender affirming care specialist? And if they did not, could they be investigated for not following standards of care? So I have that question. S37 requires insurance companies to cover gender affirming care without limits and shields gender affirming care practitioners from increases in medical malpractice insurance premiums, which protects them financially from the types of lawsuits already currently happening internationally, both internationally and in the States, by minor aged patients who claim they were rushed and or pressured into gender affirming care along with their parents and denied informed consent on the side effects and complications of medications and hormones. Carol will be digging into that deeper for you. S37 and H89 may even shield practitioners from lawsuits when there is actual negligence, because the risk of losing a lawsuit and countersuit under abusive litigation could be overly burdensome financially and mentally and emotionally. Although all gender affirming care might be considered outright criminal, not just negligent, given the side effects I just went over, the complications and the lifetime damage, both mentally and physically. So this is how legislators, by shielding one type of care, usurp parental authority and minor protections without having explicit language in either S37 or H89. So I conclude that S37 and H89 do not serve to protect youth, minors, and families, and that they shield mental and medical practices and practitioners that very well could be damaging them. And that's it.
Great, thank you. If you can take down the testimony, so because we only see you in a little box right now. Are there any questions for Renee, Melanie?
And forgive me, I'm new to the committee. I just was curious, could you describe to me what Vermont Family Alliance is and just like what kind of organization you are and like your credentials? Because other folks have brought that up when they've testified and I just am not familiar with your.
Yeah, we're just, we're a grassroots organization looking out for the interests of minors, just like everybody else, and parental rights. So Carol might be better suited to answer that question, but, I hope that answered your question. But if, we have several 100 members across the state of Vermont in all locations that are interested in making sure that we preserve our parental rights and responsibilities to raise our children. And Vermont Family Alliance believes that the parents are the experts of their own children and need to be not just involved in their child's education and healthcare, but they need to be directing it. They need to be in charge of it. They need to be at the front of their care. They need to be leading the care. Does that help explain? Is that?
I just was curious and I wasn't sure, like, there is, like, what your role was and like if you're a medical doctor or any of those things. There was just your grassroots and just.
We're a grassroots organization, and I'm a parent, you know, who knows how to read studies and knows how to look at data, and which has not been provided by people who are endorsing. Dr. Gibson has failed to provide data, and so has Polly Kosher. So we want to see some data, you know. We haven't seen any data, and I just presented you with some data, and it's from the AAP. I mean, that's a credentialed, right? You're relying on American Academy of Pediatrics for their standards of care for gender affirming care, correct? So I just provided you with some National Institute of Health and American Academy of Pediatrics studies.
Thank you. Great. Brian?
Okay.
I want to start by also acknowledging that I believe that your heart's in the right place. And I actually would like to see, this is not something I have questions for you, but I just want to validate that I would like to see, if possible, data that covers, if there was a way to do this. I'm not asking you to do this, but like, because maybe there's like someone whose job it is who can help us assemble this, like a side-by-side of like general population suicide rates, pre-op transgender youth suicide rates, suicide rates during the transition, suicide rates post-op years out, up to including what you said about like 19, there was a stat you had. I want to see like all that side-by-side just to see the data. I don't think that suicide rates alone is the reason why I would support the bill, but I want to see that. So I want to validate that. I also want to see suicide rates for conversion therapy, people who have conversion therapy, along with that, just so we could see all the different, ways that suicide affects transgender people in the process and in different treatments. I won't keep going on, but I want to see the suicide rates for just gender affirming psychotherapy, for puberty blockers, for like at every stage of the transition, just because then we can see what do they really look like for transgender people in every possible approach. And I think that would like validates what you're saying. So, but then I have questions for you. What if we were to, you said that we might be on the wrong side of history. So I'm wondering if you could tell us what the right side of history would be. And if we were to end gender affirming care, what should we do for the people who are already transgender, the people who've already transitioned and rely on the hormones, the people who are getting that care? What should we do? What should we tell children when they tell us that they're not cisgender? How should we respond to that moving forward? And what harm might this cause to those to people, from your perspective? Like if we, because what I'm hearing is end the care completely, but maybe I'm misunderstanding you.
Renee, would you like to answer? Do you
I
want to
am trying to start. Think of where to start as far as being on the wrong side of history. I would like I feel like in every single committee, and there's so many supporters of H89 in particular, I don't know how many there are of S37 specifically. I would like all the legislators to take a step back and really have this data before either of these bills are passed is what we want looked at. When I hear Dr. Gibson, who's UVM Medical Center, she's a specialist in pediatric adolescent medicine. when she was questioned yesterday on data, she said that there's emerging data. Well, I'd like to just show the data. She said there's emerging data. So show us, upload that data that they currently have. This is when Vice Chair McFawn, I believe, asked her, what are the outcomes at ages 16, 17, 18 if a child begins transitioning or begins gender affirming care at the age of 10 or 11. And she said there's emerging data, but she hasn't shared that data. And then I apologize for not recalling who asked the other question. A committee member asked Dr. Gibson, how many people at UVM Medical Center, the transgender unit, the data, how many end up just therapy or blockers, how many do hormones and surgeries. And Erica Gibson said that she doesn't have that data collated, or that she doesn't have a way to collate that data. And it seems to me like, how can we even begin to have evidence-based data if she can't collate the data? So she needs to find a way to collate the data.
So Renee, I'm sorry, I'm gonna stop you because we do want to have time for Carol, but I also want to make sure you're answering the question from Brian, which I think was more not around the data, but what do you suggest and correct me if I'm wrong, Brian, what do you suggest, or what does Vermont Family Alliance suggest that we do if we just stopped care completely, which it sounds like is what you're advocating for?
I don't know. I think that is a misunderstanding. And I'm sorry, I apologize because your question was really long, Brian. Excuse me, and I lost track. So I guess I would refer you back again to as far as what you say to people who have already transitioned. If they're happy, great, but I'm asking you to look at, before you pass this bill, I'm asking you to look at the other side of people who have regretted care. And there's a lot of people that have been damaged by this care. And I want you to, we want you to take a look at it. Hold on a second. I got to go back to, and then look at the, which number was it? Oh.
I actually think, Renee,
I want all options considered, because I think Brian made the comment yesterday that he said that, they can, was it conversion therapy is only one type of care because you're trying to make them, change their mind, align with whatever. But I think the same could be said about gender affirming care, unless under gender affirming care, therapists are allowed to treat a child to align themselves with their birth registered. That treatment needs to be made available if they want it. And so it seems like that's been banned, but that treatment needs to be made available if they want it. Does that make sense? So
that makes sense.
Like all the options are not on the table.
So I just want to be clear.
Yeah.
That makes sense. And a couple things that this bill does not do, it does not remove a parent from the equation at all. And it does not prescribe what type of gender affirming care should be provided. There is no mandate that it is only one or another. And so again, it is between the person, the parent, if the person is under age of consent, and a doctor. So that is what this bill is doing. So Brian, I think you had another question.
Yeah, I when you were describing what you want us to do, it makes me think not only of the people in Vermont, but the thousands and thousands of children and adults around the country currently receiving care that is going to be cut off from them. And I'm not saying that the answer, I don't know what the answer to this is nationally, but what should we say to them when they come to Vermont and they're looking for help? What should we say when people, what do we do as the American people? It's almost a humanitarian crisis that we will be terminating healthcare for people who rely on it already in these other places. And so this is what weighs on me with the SHIELD law, is anything we can do to send a message to those people that we're still thinking of them, And so I'm just curious, what should we say to them? If we don't pass this, what should we do? what harm might this cause to I don't know how many transgender people have transitioned out there, but
So I think I'm going to say, I think I'm going to say that at this point, because of timing and because Vermont Family Alliance is a grassroots effort, they're not a medical profession. We hear the question, right? And again,
well, we're parents and we're the experts of our children once again. Yeah. So that's our credential right there. We're the parents.
yes, you are parents, exactly. But again, this bill is not
about parents' rights.
about parents' rights, and it's not about mandating one type of care. So I think we'll leave that on the table. Any other questions for Renee before we switch to Carol? Great. Thank you, Renee.
Yep. Thank you. Okay.
Carol, welcome. Carol, you there? May have stepped away. There. Oh,
Or sometimes people can't unmute. Like that happens to me
Right, I know.
sometimes. I'm like,
I'm here.
where is that mute button? Carol, are you there?
Yep, I'm here.
Okay.
A second.
Hi there, welcome. If you can introduce yourself for the record, and then I don't see that you sent any written testimony, I don't believe. So we'll just.
Sorry about that.
No, that's okay. Provide the testimony.
I will get it sent in. This is new for me, and yeah, with everything else I have to do. Yeah.
No worries. So can you first introduce yourself, your name, and who you're with for the record, please?
Sure. My name's Carol Kaufman, and I'm with the Vermont Family Alliance.
Great.
Yeah.
So we're here to listen to you.
Okay, so
We'll go to the school. Sorry.
I'm going to agree with this, but I'm just going to go through and at the end, if you ask me what side of history is right, I'd love to talk to you about that. So anyway, thank you for this time. H89 and S37 will constrict Article 22's personal reproductive liberty without voter approval or a day in court. Companion bills S37 and H89 will protect a one-direction model of care for a minor child who may be experiencing gender dysphoria, therefore interfering with the Vermont state constitutional right to reproductive liberty. H89 and S37 do not extend equal personal reproductive protection as required under Article 22. Act 47 of 2019, purpose and policy guarantees the state of Vermont recognizes the fundamental right of every individual to choose or refuse contraception or sterilization. The state of Vermont recognizes the fundamental right of every individual who becomes pregnant to choose to carry a pregnancy to term, to give birth to a child, or to have an abortion. Prior to the November Article 22 vote, Representative George Till, Speaker of the House, Krowinski, Senator Ruth Hardy, and former Representative Ann Pugh publicly stated that Article 22 will make it difficult for future legislators to interfere with personal reproductive liberty. So, that's one question. So why this bill? Because under Article 22, reproductive liberty is open wide. So H89 and S37, by exclusively protecting the one direction gender affirming healthcare model and prohibiting so-called conversion therapy, are government interference and loss of reproductive liberty choices because patients are denied information about a care model that could allow them to resolve their dysphoria without damaging their fertility and bodies. Dr. Kenneth Zucker, long acknowledged as a foremost authority on gender identity issues, would be in violation of Vermont's standard of care. Zucker believes that gender dysphoria pre-puberty children are best served by helping them align their gender identity with their anatomic sex. This view ultimately cost him his 30-year directorship of the Child, Youth, and Family Gender Identity Clinic at the Center for Addiction and Mental Health in Toronto. Susan and Marcus Evans would also be so-called conversion therapists under H89 and S37. They are authors of Gender Dysphoria, a therapeutic model for working with children, adolescents, and young adults. Marcus Evans stated, quote, "It's another matter to start interfering with a healthy body. One would want to think very carefully before you do that." Feminist Dr. Deborah Soule, author of The End of Gender, would be another so-called conversion therapist in Vermont. She warns that mental health therapists are leaving this field because of laws limiting care to the one direction gender affirming model. Families, mental health, and medical health providers that believe in the science of two genders will become a target in Vermont under 26 VSA 3261. Quote, "Disciplinary action includes any action taken by the state board against a licensed clinician, mental health counselor, or applicant premised on the finding that the licensed clinical mental health counselor or applicant has engaged in unprofessional conduct." Dr. Soule's assertion are correct, and there's no protection that that won't happen within H89 and S37. H89 and S37 committee members should understand therapeutic gender dysphoria models in which the Vermont government has deemed conversion therapy before you vote. And actually, I would love to help you organize a panel. And if you want the experts to come in, I will work hard at Zooming them in so that you can hear the experts of Vermont that have really created this gender affirming exclusive environment. We should be able to agree that children do not have the physical, emotional, or mental capacity to protect themselves or to make life-altering decisions with or without their parents. Vermont state government has age restrictions for drinking alcohol, driving, gun ownership, smoking, and marijuana, with or without parent consent because of brain development. For the same reasons, age restrictions must be considered for H89 and S37. Standards of care are changing rapidly, and parents' rights to direct the care of their children need to be protected in law. H89 expert testimony must address minor brain development, informed consent, minor consent challenges, minor protections such as case plans, due process, and court oversight. Unlike Vermont, sister states are determining mental and medical gender care sister states are not determining mental and medical gender care options through legislation. States are rightly concerned and focused on the known permanent side effects of the gender affirming hormone treatments that are not FDA approved and the irreversible surgical options, and only in minors. H89 and S37 committees should not vote without this imperative discussion. I will submit testimonials from individuals describing their experiences. Even though they are not from Vermont, their care was exclusively gender affirming, as would be protected by H89 and S37, and also recommended by some state and national medical societies. I hope you will read each one. Will H89 and S37 protect minors and adults wanting to detransition their biological sex? And will insurance cover all mental and medical treatment needed? Tricia Mosley decided to stop transition. Quote, "No doctors will help me fix this, and insurance is paying for nothing." Consider one of the national cases of Chloe Cole, who is suing Kaiser Permanente of California. In Chloe Cole's lawsuit, the defendants falsely informed Chloe and her parents that Chloe's gender dysphoria would not resolve unless Chloe socially and medically transitioned to appear more like a male. Quote, the vast majority of childhood gender dysphoria cases resolve by the time the child reaches adulthood, with the patient's self-perception reverting back to align with their biological sex. Under Chloe's One Direction gender-affirming model of care, quote, between 13 to 17 years old, Chloe underwent harmful transgender treatment, specifically puberty blockers, off-label sex, cross-sex hormone treatment, and a double mastectomy. Parents must be free to find the individual healthcare, transparency, and information that is necessary for them to direct the medical treatment that is best for their minor child beyond the One Direction gender-affirming model care, and government must not interfere. Finally, the Vermont state government began to codify the One Direction gender-affirming standard of care model into Vermont law, interfering with reproductive liberty and the parental right to direct their child's mental and medical health care through the following statutes. Conversion therapy was prohibited in 18 VSA 8351, by default protecting the One Direction gender-affirming care model. Vermont began to interfere with the parent-child and doctor relationship. Act 35 of 2017, quote, this bill proposes to allow minors to consent to mental health treatment for any condition related to the minor's sexual orientation or gender identity without parental knowledge. Under Act 35, parents are not able to even select the most appropriate counselor for their children. 16 VSA 136 requires, quote, at a minimum, condoms shall be placed in locations that are safe and readily accessible to students, including the school nurse's office. Again, parents are not involved and have no input over adult access to their children. Parents are reporting gender ideology influences within their child's public school at an early age with books and curricula they are unaware of. Both S37 and H89 will protect, quote, any act or omission undertaken to aid or encourage or attempt to aid or encourage any person in the exercise and enjoyment of attempted gender-affirming healthcare services secured by the state or to provide insurance coverage for such services. This alone is terrifying. I will submit an amicus brief by Dr. Erica E. Anderson, PhD, with my testimony. Dr. Anderson is a clinical psychologist practicing in Berkeley, California, with over 40 years of experience and is transgender. Dr. Anderson argues, quote, whether a minor experienced gender incongruence would transition socially is a major and potentially life-altering decision that requires parental involvement for many reasons. Dr. Anderson's table of authorities is exhaustive. The world has a problem with minor sexual exploitation. I recommend each committee member research Operation Underground. It's understandable that concern about suicide compels action. Each committee member must consider today's exponential suicide rate with the gender dysphoric demographic. And I want you guys to know that Vermont Family Alliance care about them also. So, let me take my breath. If suicide is the result of the absence of one direction gender affirming healthcare model, then why doesn't history show suicide rates when today's gender affirming model was not an option of care? Care must flow in both directions. Let's work to protect children by creating legislation that works for all children while not constricting reproductive liberty protected under Article 22. Thank you.
Thank you, Carol. And again, I just want to state that nothing in this bill restricts a parent's rights. So any questions for Carol? Okay.
I wrote a lot of things down, but I don't want to ask all of this. I'm just trying to like,
One or two.
yeah, exactly. I guess like you referred to gender affirming care as being one way, but and I don't know if you said this to the previous witness, but like if a person comes to therapy and says, I want to feel different, like a therapist doesn't say, we heard this from witnesses, like we don't say in gender affirming care, you must do this or that. And if a person wants to work towards feeling a certain way, and that's really what they want, we're there with them to walk with them as they try to figure out how to feel that way. Gender affirming care doesn't direct people in one direction or another. It actually leaves it open. Whereas my understanding is conversion therapy says we are doing this one thing. Can you explain, do you know if in conversion therapy, the individual has to consent, or can a parent in conversion therapy make the decision and force it on a child?
Well, I would think that you're going to have bad actors in both. So
Actually, no. If that happens, yeah, but I think you're right. It can happen, but under the current system, if someone can report you to the Office of Professional Regulation, so like what the question isn't about bad actors; it's about consent. I don't want to get, and I don't mean to interrupt you, but I don't want to like go off on another tangent. The question
Right.
is, in conversion therapy, does the individual have to consent? Under current law, the individual has to consent for therapy at any age. You can't force any therapy on anyone. The parents don't have to consent. And I know you have a problem with that. And like, I acknowledge that and I honor that. But under conversion therapy, does the individual have to consent? It sounds like the parents do, because it's something parents want done on their kids, but does the kid have to consent under conversion therapy?
Well, the conversion therapists that I listed, and they will say publicly that they are considered conversion therapists, their focus is rightly on therapy. It's totally on trying to work through the adverse effects in the testimonies that, and so when you're talking about, is their goal to go against the desires of the child? I don't know any good therapist who would have that goal, would not be to go against, but like Dr. Zucker from Canada, in working with children, because he knows that the vast majority of them are going to make it through puberty and be at peace with their birth sex. And so his opinion was, yes, we work with them to align themselves and to be at peace with their birth sex pre-puberty. That was his goal, and it got him tossed out of the Toronto clinic.
So Carol, thank you. And I would love to have you submit your testimony in writing. I think it would be very helpful. I want to reiterate what you both have said and Brian has said, and that we all agree. We all know as we always do in the legislature, we all may disagree, but we know at the end of the day, we all want what's for the best for our children. And so I hope we can all leave here today remembering that. Again, this bill does not change consent for minors. It does not take away a parent's right. And it, again, I think solidifies our stated goal with Article 22 that reproductive health should be between, and now gender affirming care should be between a doctor and the patient and a parent when appropriate for age. So I think it's best we leave it here. Please send your testimony in, and you have my contact information. So if there's anything else you want to send, please do so as well. Thank you, Carol. Thank you, Renee, if you're still on.
Yeah, thanks. And if you want to set up a panel and really listen to experts, I'm not claiming to be an expert, but I do listen to them. And I think it would be better for Vermont if you could hear both sides from experts. Thank you.
Thank you, Carol. And I think unless there's questions or comments, we are good for the day. Yes.
I do have a comment. There was a lot of discussion about a House bill, and I just want to see if you can level set.
Yes. So H89 is the campaign, and I might look to Ledge Council. H89 is a companion bill to S37. H89 has already been passed out of the House. It is in the Senate, and I have my notes, but since you all are here, I'm going to let you say exactly what the differences are between the two. Not the exact differences, but the overall intent of one versus the intent of the other.
Sure. Jennifer Carvey, Legislative Council. H89 deals with civil and criminal procedures around legally protected healthcare activities. So it's looking more at some of the issues that have come up around extradition from other states and legally and abusive litigation. So using the legal system to try to discourage someone from engaging in particular legally protected healthcare. So this has been what we've been talking about, is really focused on health insurance coverage of and the healthcare provider kind of delivery of care side of things, as opposed to the legal process around legally protected healthcare.
First, Daisy, did that answer your question?
Yeah, I just wanted to put it out there that this testimony is actually related to S37, which is not. So it sounds like this conversation kind of floats in, or the parental rights is kind of.
They're floating it in between.
Yeah, it's floating in between. It doesn't really have a spot.
Melanie?
And just for clarity's sake, the House bill also did not change parental consent at all. Is that correct?
I'm not aware of anything in either of these bills that affects parental consent any different from the current status quo. It's really looking at legal protections for those engaged in legally protected healthcare activity.
Bobby?
Just for ultimate clarity too, neither of these bills prescribe what treatments are going to be made under. They don't prescribe what patients are going to be undergoing. They're just protecting doctors from civil and criminal penalties, right?
Right. This does not change the standard of care, does not change healthcare provider and patient, and as the chair said, in the gender affirming care context, that for minors, parental involvement in determining what is the care for the patient. So.
Well, because to follow up on my question about the whole idea of one direction, there must be a number of patients who seek gender affirming therapy, and then there must be a number of people who actually fully transition, whether it's medically or surgical, and those numbers are not going to be the same. I mean, it would be astounding if they were. So my question is, there must be a lot of people who seek care and decide to go in a different direction that's not the one direction. And I don't know if we have those numbers, but it seems logical to me that that's still possible with these bills. The bills don't say what direction they have to go. That's my point. I mean, and I'm asking if Renee and Carol want to comment on that, but.
We do not have the numbers. No, we do not have the numbers. And no, this does not prescribe one direction of care. Alan and then Brian.
Okay, well, right now, if anybody goes through this transformation, there's no insurance that covers that at this time?
So It's up to, if it's a commercial insurance, it's up to the commercial
So some do right
insurance.
now, some pay.
Well, we're going to hear from insurance companies tomorrow, so I say we suggest.
What we're saying here is they will be responsible for payments.
So what this bill says
Either
is that
Medicaid or,
for general affirming care,
yeah,
it would be covered and there would be cost sharing requirements for, I'm trying to get to the language.
Do you want Cameron to?
Yes, that'd be great.
Sure.
But she's going to.
Or I
Cameron Adam, Julie Legislative Council. This bill does require that in statute that insurance and Medicaid cover gender affirming healthcare services and abortion related services. You will hear probably tomorrow.
Yes.
From DIVA and the insurance carriers about what is already covered.
Okay.
And so I don't want to get ahead of.
Yeah.
Hear what's presently
Yeah.
covered, what's already required to be covered as part of the state's essential health benchmark plan.
Right.
So you'll
Yes.
get a full explanation tomorrow.
Yeah, and I also want to, just want to put out there that when we talk about gender affirming care, it is a wide swath of possibilities that a person will seek out. And it is not, we've been hearing about, transformations. It may not be
Exactly.
transformations. So I want to be clear, it could be social, it could be changing pronouns, all the way up to something more. So I just, and I'm not commenting on what you said, I just want to say, it's a broad abilities for people to have the capability to get the
there's
care they
such a
need.
wide scope of this.
Yes.
It's going to have effect on the Vermont people financially.
We will, in regards to premiums, are you talking about that? We will hear,
And Medicaid, everything else.
we don't know that, so we'll hear more tomorrow. Brian?
Yeah, I think I feel like this testimony took me down a road that now that I'm at the end of it, I'm looking back and I'm like, the argument really isn't whether or not we are going to start restricting something we already allow the people of Vermont to have. It's about, are we going to protect people for providing that service we already give people? And so as much as I do want to know all this data now, I don't think that would affect my decision here. And I can't believe that, like, we're even questioning, like, taking something away from people they already have, I just couldn't do that to people. So I think just you acknowledging, like, or people acknowledging, like you in the plural, like, ustedes or whatever, like, that people saying, people saying like, this isn't about what gender affirming care is. It's about, it's about a shield so that people can't be sued, et cetera, for something that we already allow, I think it's just important to recognize, like, that it's not changing consent. It does make me question, though, have other questions, but I feel like they're not really relevant to this bill. So I'd like to know more data about the issue, but I don't know if I need this testimony before we vote on something or whatever. But
Daisy and then Alan.
I just want to give a tiny example that, as you were speaking, really kind of grounded me in that. When I go to my SLP, they share an office with someone who does voice therapy. And so it may be as simple as someone who gets voice therapy to, adjust their speech or something to a way that they prefer. And so that's a service that would go away. And, like, I don't know, thank you for saying that, because it is something that people are already doing. And it's a simple service that is in the same room, in the same desk that I go to for something. And it's just this type of specialty care that somebody is already trained in. And yeah, thank you for that point.
I just think that we've gone a long ways away from what the intent originally was. It was the shield bill. It was to protect the providers of all this. We've gotten into a real big,
Discussion, but I think the bill is still a shield bill. I mean, that's what it is.
Yeah.
The discussion has taken us out here.
Yeah.
But this
We keep it pulled out. So it's like, yeah, it's really.
this is still a shield bill. It does not change parental rights. It does not prescribe what care has to be provided. And I think, as we discussed earlier, the established norms that we've had in this country are changing. And we want to say, because already we have reproductive health care in Vermont, we want to shield our providers who provide that care within their standard and scope of practice.
But we also want to do the best we can for the patients.
Absolutely.
I'm at the point right now, I don't know where I stand because they made sense of the unintended consequences of all this. And my own common sense tells me that in my own family, I don't think a lot of these children, my grandkids and my children themselves, could make those decisions. And what I think a therapist should do is help them along and just being comfortable.
That's what gender affirming care is.
Okay.
That's what it is. That's what it is. Yeah.
So, but that brings me to the point is give them all the therapy they need until they reach a certain age. Just like I took out of heart. You can't get married now until you're 18. You gotta have a driver's license, you're 16. So why is this so much different?
Yeah.
I don't
We
think.
can provide the therapy until this certain age group, but then they should be educated enough to realize what they want.
So here's my personal take on this is that we require consent, right, for children up to a certain age. And we sitting around this table, some of us are medical professionals. I'm not a medical professional. And I want a medical professional to be involved in that decision. I do not want the government involved in that decision. And us sitting here and prescribing in this bill, which we're not at this point, what type of care or at what age it has or can't be given, we're putting the government in that role. And that's not our job. It's a medical professional's job to work with a parent and a family. Again, I'm just giving you my opinion. Fast.
I know. I appreciate that, Lori.
All right.
May I comment, please? Because I kind of feel like that our testimonies have been misframed, and I didn't really spend I didn't spend any time at all saying how you're usurping parental rights. We very much recognize and acknowledge that there's not explicit language in S37 regarding parental rights or minor consent. Okay, but I ask you again to look at item number 6 on my testimony and consider the side effects and whether or not gender affirming care is really helpful to these parents if, with experiencing gender dysphoria and gender incongruence. And then it's my other point. And, and then I have a question, and Brian might be able to know better on this and answer this. But so if minors, along with their parents, desire care that brings them into alignment with their birth registered sex to help them thrive, can a gender affirming care practitioner provide this service? Or would it be considered conversion therapy, which has been outlawed under Title 18? And then I didn't see on the UVM Medical Center site the link that Dr. Gibson shared for like the resources that are available for gender affirming care. And so I didn't see anything on there that shows that do gender affirming care practitioners provide resources to minors and parents that explain the universal sense of awkwardness and uncomfortableness among youth during adolescence and the process of puberty? Are those some of the resources that are shared with youth as well? So
I appreciate the question. That is not on the table here in this bill. We are not changing what is available.
So you don't care about the side effects then? Is that what you're saying?
So you know what, Renee, I'm not gonna argue with you on this. I don't want to do that. I appreciate your questions, and as a grassroots effort, I know you have some resources to gather the answers you need. What we're doing here is not changing what is available today for care. We're not prescribing care, and we're not taking away parental rights. So I think we just really need to leave the testimony at this today. So I appreciate it. Art, I know you had a question.
Yeah, I did. I had a very specific question, and not to hold this up, probably everybody wants to leave, but on page 1 of the bill, and my question's around, what I was going to ask for is someplace to go to look at what the parental responsibility is.
Consent.
And I noticed here, gender affirming healthcare service does not include conversion therapy as defined in 18 BSA. Does 18 BSA spell out the parental piece somewhere in there? Is that where it would be? Just so I can be familiar with that. And also, does 18 BSA make gender affirming healthcare services legal in Vermont? Is that what does it, or?
So I think what I'm going to do is, we've heard the questions. I'm going to ask Jen and Ameren, right, to either put something together or come back. We'll schedule some time, maybe for 15, 20 minutes for them.
Yeah, let's see. I just want to know in my head what this is.
Those are very good questions, and we'll get them on the table for you. Yes.
Yeah, I just, like, Renee asked me some questions and I feel like I'd like to answer it, but I'm not the witness. But I think for the record though, we might need like a gender affirming healthcare 101, because I feel like there's misconceptions. Because I can tell you, I will say this, even though I'm not the witness, that any rostered licensed like mental health practitioner following standards of care is going to do a full clinical assessment looking for all mental health issues and treat everything in addition to gender dysphoria, and that there's so many possible outcomes and treatment approaches for gender dysphoria. And for some people who have trauma, it is working through a trauma, and then it changes how their gender expression. And then there's other people who they're an adult and they want to have a sex change. And there's some people who never want to and who just have to learn to be gender fluid, or like, you know, and so I think it'd be good to hear what it is from like experts on the record, all the components, just to get it out there. Cause I think, that would be useful for the record. And I think I answered some of your questions indirectly in the process.
So I think what I'm going to suggest is that if you're to go back and watch Dr. Gibson's testimony, and then link through some of the items she provided in her testimony, one of which was supporting the parent for transgender children. That does a very good job of describing kind of the process. So, and then if people still have questions next week, we can think about bringing someone else in.
Okay.
Great. Thank you, everyone. We are back here tomorrow at